Assalamualaikum. Today we will discuss one of the most common symptom of neurological disorder is headache. Okay, any question related with the headache you should be asked in the last because this is a very common topic and I think everyone is suffered from this condition. Okay, what is simple definition of headache? Explain. There is no WHO definition, no FDA related definition. Simple definition. Pain in the head. Very good. Okay. Any other? In your words. Yes? Discomfort in the head. Okay. So these are simple definitions. So that's why we have not discussed the definition. So pain in the head and face or discomfort in the head or face, these are the common definitions. We are directly going to the epidemiology. 99% of women are affected from the headache and 93% of men have also affected from the headache during their lifetime. The reasons are a lot of reasons we are discussed. Prevalence is highest between the age 25 to 55 because if the patient is a headache age less than 55 it is less commonly and after 55 the common reason of the headache is the secondary headache. That's why the common age of the headache is young age up to the old age. And estimated, this is a survey of the United States, 30 million patients have suffered migraine in the United States and 10 million have suffered to the chronic daily headache. What is chronic daily headache? Any idea? Half definition is mentioned. If patient is complaining of the headache more than 15 days per month for last 3 months. So patient is history of the headache for last 3 months and the headache is persistent more than 15 days per month. So a term used for this headache is the chronic daily headache. Lot of causes of these are chronic daily headache, but this is a simple definition. So in United States, 30 million are suffer from the migraine and 10 million are suffer from the chronic daily headache. Okay, these are different pain sensitive areas. So these 6 are reasons of headache. The most common and initial reason is the scale and it is blood supply. So there is the irritation or inflammation of the scale or it is blood supply. The second is the venous sinuses which carries the blood. There is the irritation or inflammation of the venous sinuses. Third is the parts of the dura mater. There is the irritation or inflammation of dura. Fourth is the arteries of meninges and large cerebral arteries. There is the inflammation or irritation or pressure. Other is the pain sensitive fibers of the 5th, 9th and 10th cranial nerve, but most common is the 5th cranial nerve. So trigeminal nerves or trigeminal neurons are very responsible for the headache, especially for the migraine. And last, head and neck muscles. Why? Because the headache of the migraine sometimes radiate into the neck. And we are confused, this is a headache or this patient is a cervical issue. The reason of the migraine headache or sometimes tension headache is radiate into the neck because there is an involvement of the neck muscles. So these 6 areas responsible for the headache. Okay, what causes headache? There is the involvement of arteries, involvement of the veins, involvement of the nerves, involvement of the muscle. All are responsible for the pathogenesis of the headache. So distension, traction or dilatation of intracranial or extracranial arteries. Traction, displacement of large intracranial vein on their dura envelope. Compression, traction or inflammation of the cranial or spinal nerves with spasm, inflammation or trauma to the cranial or cervical muscles. Then meningeal irritation and sometimes raised intracranial pressure. This is a very dangerous reason of the headache. And finally, maybe headache of the ocular origin. So a simple pathophysiology of patient with a headache, any type of headache. Okay, what are common non-neurological causes of headache? Hypertension. Okay, this is most probably secondary cause.
Migraine.
Okay,
Migraine.
migraine is neurological cause. Anemia. Anemia is most common cause of headache. If patient came with a headache, we are thinking this is a brain issue, brain tumor, brain stroke, migraine cluster, but the anemia is most common. And anemia is most common of headache in children. Menstruation. Okay, good. And drugs are mostly cause of the secondary. So we are classified as secondary, primary, and non-neurology. Okay, drugs. Which drug is the most common? Cause headache. No. Any single drug which can cause severe headache if you are taking is the nitroglycerin. Sodium nitroglycerin. If you are going to the cardiac ward and patient is given the nitroglycerin, they are complaining of the severe headache. So other drugs also which cause vasospasm like amphetamine, cocaine, but the nitroglycerin is very common drug in our setup. So one is the drug, second is the anemia, very good. Other causes?
Specific foods.
Sinusitis, okay.
Sir, foods like spicy foods. Spicy foods.
Why spicy food? Spicy food can cause maybe migraine.
No, sir, headache.
Headache, really?
It is a common cause.
Okay. Other? Any systemic infection. If you are sore throat, you have fever, can cause headache. Sleep disturbance is very common. If the poor sleep, you can suffer from the headache. If poor sleep, you can suffer from the headache. So these are the common non-neurological causes. And other most common non-neurological causes are refractory error. So if any young patient came in my OPD with a complaining of the headache, before I am diagnosed a migraine or tension type headache, I am advised one is the blood CT to rule out the anemia. Second, I am advised to the visual acuity or eye examination. And third, history of the sleep is very important in these patients. So these are non-neurological causes. Before we came into the primary or secondary headaches, the common is the anemia. So every patient with a headache, think of the anemia before you think of the brain tumor. Refractory error, so must visit to the eye specialist for two reasons. The first reason is the visual acuity and second is the fundoscopy for papillary edema. The third is the poor sleep and poor sleep. Systemic infection, any systemic infection like viral can cause headache. Hypotension, common into the students, headache. Hypoglycemia can cause headache. So these are the common non-neurological causes before we are thinking to advise the CT scan or other invasive investigation. Okay, now we will come to the exact classification of headache. Primary headache, which is account for 90% cases. Secondary headache, which is only account for the 10% cases. Third is the including other causes like cranial neuralgia, central and primary facial pain and other headaches. So facial pain is also included in the classification of the headache. Okay, this is the International Headache Society classification of the primary headache. Migraine, tension type headache, cluster headache and other trigeminal autonomic cephalgia. Why we are called the trigeminal autonomic cephalgia? In this condition, patient present with the autonomic symptoms. Normally the symptoms of the headache associated are the nausea, vomiting, but in cluster headache or trigeminal autonomic cephalgia, patient present with a severe headache with one eye involvement, redness, lacrimation, ptosis, conjunctival irritation. So these are the autonomic symptoms. So these are included into the trigeminal autonomic cephalgia, and finally fourth is the other primary headache. So which headache is more common? No. Tension headache is more common. Second most common is the migraine. Okay, secondary headache. Lot of reasons. Trauma, head trauma or neck trauma, cranial or cervical vascular disorder like stroke, non-vascular intracranial disorders, substance or it is withdrawal like patient is a CNS stimulant, cocaine, amphetamine, or suddenly withdrawal of the benzodiazepine. Infection, most probably CNS infection like meningitis, viral encephalitis, HIV, or cerebral malaria. Blood disorders, facial pain, common facial pain like trigeminal neuralgia, if you are read this topic. Other pain due to the neck, eyes, ear, nose, sinus, teeth, mouth, or other cranial structures. If you are exclude all causes, then think of a psychiatric disorder. So psychiatric disorder headache is diagnosis of the exclude. You are exclude other causes, then you are diagnosed with psychiatric disorder. Okay, so these are the causes of the secondary headache. Okay, approach to a patient with a headache. If you are in the OPD and patient came with a complaining of the headache, which history is taken from your side? So questions are very important for the diagnosis of the proper headache reason. And to identify causes of the acute headache, it required immediate therapy. Must be exclude acute headache causes. Need for further investigations. We are called red flag signs. Okay. Either this patient headache is required any investigation or not. Most probably due to the secondary cause. So these are some common type of headache and their presentation. And most common type is tension headache. So where is the pain of the tension headache? Most probably frontal area or bent-like sensation around the head. Second is the migraine. 80% cases, or some books say 70% cases it is unilateral, and 20 to 30% cases migraine may be bilateral or generalized. Third is the sinus headache. What is the common site of the sinus headache?
Behind eyes. Sir, orbital.
Okay, so it depends on which sinus is involved. If there is the sinuses involvement of the frontal sinus, involvement of the okay, frontal sinus. Where is the common site of the frontal sinus?
Sir, on the
There
forehead.
is a forehead. Maxillary sinus. So there is an involvement of the bilateral mid face or maxillary area. So sinus involvement is responsible for the location of the headache. Finally, cluster headache. Any idea of the cluster headache?
Around the orbit.
Around the orbit. Okay, very good. Unilateral. Okay, but it is associated with the redness of eye, ptosis, okay, and lacrimation. So we are called cluster headache is the trigeminal autonomic cephalgia. And cluster headache is common into the male, and migraine is common into the female. History, very, very, very important. Onset. What is the importance of onset? So, it is acute onset or it is chronic onset. What are the causes of acute onset in your mind? Hypertension is most probably not an acute onset. This patient is a hypertensive emergency. So you should add hypertensive emergency. Okay, second? arthritis. Okay. Very good. Subarachnoid hemorrhage. Severe, sudden, thunderclap, worsening of headache of life. So one reason is the subarachnoid hemorrhage. Second is the temporal arthritis, hypertensive emergency. What are other causes? Sinusitis. Okay, but mostly it is included into the gradual. So there is history of the 2 to 3 weeks or 1 week. Yes. Meningitis. Very good. CNS infection cause severe headache and migraine. Migraine attack is severe, sudden, cluster headache, severe, sudden. So these are the some causes of the acute onset headache. But episodic, but acute, severe headache, improve with rest or improve with analgesic. Then once again severe headache. Okay, what are the causes of the chronic headache? Directly cancer. Anemia, good. Refractory error, very good.
Aneurysm.
Dehydration, okay, in children is common.
Aneurysm.
Aneurysm is caused sudden headache, subarachnoid, thunderclap. Other chronic hypertension, tension type headache, chronic migraine. We are called the chronic daily headache. Analgesic overuse headache. Overuse of analgesic can cause headache. So these are the brain SOL, space occupying lesion, like any cyst in the brain, any tumor or any abscess in the brain. So what commonly we are called the space occupying lesion. So these are the causes of the gradual onset. Location, very important. What is the importance of location? Okay. Example of the locations of the headache. Very good. So there is the involvement of the ocular orbit is helpful for the cluster headache. What are the other causes of ocular headache? Yes, glaucoma. So ocular. Other locations example? Yes. Sinusitis. So where? Either it is involved in the frontal area, if the frontal sinusitis, either it is involvement of the maxillary area, if the involvement of the maxillary sinusitis. Okay, any other example? Migraine, which is unilateral. Patient saying the pain is start from the temporal area. Overall, two reasons of the temporal headache. One is the migraine and second is the temporal arthritis. One is occurring to the young age and second is occurring to the old age. Okay, what are other causes of the location? Tension headache. Any example of tension headache? Any common signs of tension headache? So, okay, two areas for the tension headache. One is the frontal area and second is the generalized like bend around the head. So these are the common side of the headache. Duration, okay, episodic or gradual, and every headache duration is different, like migraine and cluster we are discussing the separate topics of the migraine and cluster. Frequency, mild, moderate, severe. The question is asked from your side, either due to this headache you are perform daily activities or not. Either your headache is worse on daily activities, so it show the frequency, mild, moderate, severe, or you are sometimes asked, give the number of severity of your headache from 1 to 10. If it is more severe, patient says 10. If it is mild, moderate, patient says 5 to 6. If it is mild, patient says 1 to 2. So there are the different questions you are asked. Progression. What is the importance of progression? Yes, very good. So initially it is mild, it is unilateral, then it is in shift or replaced into the moderate to severe, and it may be the generalized. Initially the duration of the headache is short, but after with the passage of the time, the duration is more increased. Character, very important. What is the importance of character? Throbbing or pulsatile. Favorite? Migraine, very good. Any other example?
Sharp.
Sharp.
Severe.
Yes. Example of sharp.
Trigeminal neuralgia.
Okay. It is sharp and shock-like. It involves the face. So trigeminal neuralgia. But we are discussing the headache. Okay. What is the character of the cluster headache? It is ocular, male's predominance. What is character? It is the severe, sharp, knife-like. There is the insertion of the knife in the eye. This is very sharp. So some headaches are the very worsening headaches. Cluster, trigeminal neuralgia, and subarachnoid neuralgia. So these are the more worsening headache of reasons and compared to the other headaches. Okay, what is the character of the tension headache?
Throbbing.
No.
Aching.
Dull.
Dull aching.
Heaviness. Okay. And now getting into the aggravating factors and associated symptoms. Examples of aggravating factors. So photophobia and phonophobia aggravate the migraine, sometimes aggravate the tension headache. Okay. Other examples? Very good. The patient is worsening of the headache when lean forward. Patient going to the ruku, there is the worsening of headache, there is the sinusitis. Okay. Any other examples? Exertion. Which headache? Which headache? Sorry. No. Other headache, raised ICP, worse on coughing, straining, walking. Okay, so these are the aggravating factors. When patient is the headache, when patient is eat chocolate, coffee, think of the migraine, dairy products. And what about the associated symptoms? Nausea, vomiting, photophobia, phonophobia, lacrimation, ptosis, RRs, very good. What are relieving factors? Dark environment, migraine, even for tension headache. Other? Sleep, rest, and finally painkillers. Okay? Any importance of timing? So, early morning sinusitis if the patient is headache associated with the flu or rhinitis. Any other example? But there is no specific type. So headache of raised intracranial pressure. ठीक है. So headache due to the raised intracranial pressure which is worse into the late night or early morning. So if the patient is awake in the late night or early morning, think of the two headaches. One is the raised intracranial pressure, second is the sinusitis. Okay? And severity we have already discussed the mild, moderate and severe. So the tension type headache mostly include into the mild to moderate. Migraine mostly include into the moderate to severe. Cluster headache is mostly included into the severe. Okay, we have discussed lot of things. Migraine headache more frequent into the females, young adults. Cluster headache most commonly occur into the male. Cranial arthritis or temporal arthritis more common into the old age. If the patient is aged more than 50 years and he is complaining of the new onset headache which is involved into the temporal area, you should be advised the ESR and C-reactive protein. If the patient ESR is 80 to 100 or C-reactive protein is more, think of the temporal arthritis. So before patient being lost, you should start the steroids. Okay? Onset and progress we have already discussed. Acute onset, migraine, meningitis, subarachnoid hemorrhage. Progressive worsening headache, tension type headache also include into the raised intracranial pressure. Chronic, recurrent and non-progressive daily headache months to year like migraine, cluster headache and tension type headache. So we are classified on the basis of the onset, acute, chronic progressive, chronic recurrent and non-progressive. Frequency and duration. Okay. What is the maximum duration of the tension headache?
32.
Tension headache maximum duration depends on the acute or gradual. So most probably tension headache is mostly taken for the 7 days until you are not taking any painkillers, or it may be the worst more than to the 7 days. What about the migraine duration? 4 hours to 72 hours. If it is more than 72 hours, we are called the status migrainous. It is an emergency. Like epilepsy fits, duration is less than 5 minutes. If these are more than 5 minutes, we are called the status epilepticus. Like migraine, normal duration is less than 72 hours. If it is persistent more than 72 hours, continue unilateral headache, then we are labeled is the status migrainous and treated with the IV form. In simple migraine, we are treated with the oral form. Okay. The third headache of the cluster headache, 15 to 30 minutes. There is the clusters, bunch of clusters. That's why we are called the patient is a cluster headache. The duration is very short. So duration is also very important for these type of the headache. Site of headache we have already discussed. Tension headache, generalized, bed-like, or sometimes by occipital. Patient is complaining of the occipital headache. So we are confused, either this is a tension headache or it is due to the patient is the cervical problem. That's why the headache may be, receptors may be also involved in the neck muscles. The second is the migraine with aura. What is aura? What is definition of aura? Yes. And autonomic symptoms. Before the start of the attack of the migraine, patient is complaining of the abdominal pain or abdominal blocking. So these are the common symptoms of the aura. We are classified into the visual, sensory, and autonomic. Yes. No, there is no tremors in the aura. No, patient is only feeling of the, there is the numbness of the arm, numbness of the fingers before the migraine. And the second is the migraine without aura, which is more common as compared to the migraine with aura. Cluster headache invariably limited to the same side of the head in any given attack and usually periorbital. We are already discussed. Meningitis often predominant occipital, but mostly it is generalized. Cranial arthritis manifest by the localized temporal headache. We are already discussed if the age is more than 50 years, with PSR is more than 60 to 70, think of the temporal arthritis. Quality of pain or character of pain. Tension type, pressing, squeezing, tight or heaviness or dull headache. Migraine headache, throbbing, pounding, pulsatile. Headache due to the intracranial lesion, relatively mild or moderate. Precipitating aggravating factors, already we are discussed. Tension headache induced or aggravated by the emotional factor. Patient is history of the depression or anxiety. Dairy products also responsible for the migraine. Hormonal problems also associated with the migraine. Environmental, visual or addictive triggering factors. Sinusitis worsening on the pending we are already discussed. Frequency, duration and diurnal variation. Tension headache often persistent and may worsen as the day progresses. When patient is awake in the morning, there is no headache. When the patient at the time 10 a.m. or 11 a.m., patient is feeling of the mild headache. When the time is diverted into the 2 p.m. or 3 p.m., the headache is the moderate. When the time is going into the 7 p.m. or 9 p.m., the pain is the severe. So the headache of the tension type headache, it is the progressive headache. Migraine headache, the frequency is variable and unpredictable. Also variation. So the duration of the migraine headache from the 4 to 72 hours. Cluster headaches, repeatedly over a period of weeks or months. Often there is a 1 or 2 attacks daily. The duration of the cluster headache is 20 minutes, 10 minutes or 30 minutes. But bundle of clusters. There is a bunch of clusters in the head. Personal history and habits are very important. So one is the alcoholic history and sleep pattern. So patient is poor sleep, which is worsening of the headache. Patient is oversleep, which is also worsening of the headache. General medical history, there is a history of hypertension, pregnancy or postpartum, and history of HIV is very important. Family history, migraine headache is the 50% family history is positive into the migraine headache. There is no family history of the tension type headache, no family history of the cluster headache. So in 50% cases, migraine history is positive. Medication overuse headache. A simple definition: patient is taken painkillers more than 15 days per month for last 3 months. So the headache due to the any reason is converted to the medication or analgesic overuse headache. Physical examination. Vitals. Hypotension can cause headache. Hypertension can cause headache. Now came into the pulse. Pulse irregular, atrial fibrillation sometimes can cause headache. The most important is the fundoscopy. Fundoscopy is very important to rule out the papilloedema, and also the visual history is very important. Visual acuity is very important to rule out the refractory cause of the headache. If the patient age is more than 50 years or 60 years, the examination of the temporal area is very important. If the pulsatile temporal arteries with unilateral headache, think of the temporal arteritis. ENT examination is very important to rule out the sinusitis, and before this examination, along with the vitals, look for the anemia, which is not mentioned in this slide. Neurological examination: if the patient is a severe headache, patient is oriented, anxious, confused or drowsy. Cranial nerves are very important. 3 cranial nerves are very important related with the headache. Overall, all cranial nerves, but 3 is very important. Second, optic for visual acuity and papilloedema. Third is the oculomotor nerve, and 6th cranial nerve. Because the patient is a severe headache or patient is the 3rd cranial nerve or 6th cranial nerve, think this patient is the brain involvement. So further examination. Motor examination, if you feel the patient is a motor weakness. Sensory examination, coordination and gait is very important. And finally, signs of meningeal irritation. What are the causes of neck stiffness? I am not asking about the meningeal irritation, signs of meningeal irritation. I am only asked about the what are the causes of the neck stiffness. Meningitis. Okay, one very good. Subarachnoid hemorrhage. What is the difference between meningitis and subarachnoid hemorrhage? Fever is more common into the meningitis and fever not present into the subarachnoid hemorrhage. Okay, surprisingly, what is the 3rd cause of the neck stiffness? So, if cerebral malaria involves the meninges, then neck stiffness. What is the 3rd cause? Very good. Cervical spondylosis. If the patient age is more than 60 years and patient is degenerative disease, then patient is the severe pain when move the neck position. So the 3rd cause of the neck stiffness is the cervical spondylosis. So overall 3 causes: meningitis, subarachnoid hemorrhage, and 3rd is the cervical spondylosis. But the other signs of the meningeal irritations are positive into the meningitis. Subarachnoid hemorrhage, only neck stiffness. Cervical spondylosis, only neck stiffness. But the curving sign and Brzezinski sign, these are only positive into the meningitis. Okay, very, very important neurological examination. Tension type headache, completely normal neurological examination. Other causes are the small percentage of hemorrhage. Okay, localizing sign. What is the localizing sign? If you are patient complaining of the headache and you are examined, the patient is the 3rd nerve palsy, or sick nerve palsy or patient in the hemiplegia, we are called the localizing sign. Papilloedema, if you are doing the fundoscopy, the reason of the papilloedema is the raised intracranial pressure and space occupying lesion. So lot of causes of space occupying lesion, not only the brain cancer. Okay, signs of meningeal irritation if the involvement of the meninges. Okay, red flag signs. What is the meaning of red flag? Alarming sign. There is a need of investigations. So, progressive headache over month. Initially, patient is saying there is a mild headache, but with the passage of time, there is a headache is more worse, and you are doing the fundoscopy would show papilloedema. Okay, so investigation of joints is the CT scan or MRI. We are called the neuroimaging. Then new or different headache. Initially patient complaining of the unilateral headache. With the passage of the time it is complaining of the generalized headache. With the passage of the time it is more severe. There is the different locations of the headache with different character. Then you should do the neuroimaging, CT scan or MRI. Third is the worsening headache ever. So we are called thunderclap headache. Think of the subarachnoid hemorrhage. Any headache of maximum severity at onset, sudden and severe headache at first time. Onset after the 50 years of the age. That's why I am calling the headache is common into the young age. If it is more than 50 years, think of the other reason, temporal arthritis or any other space occupying lesion. Symptoms of the systemic illness. The patient is a severe high-grade fever, altered mental status, and then you should do the CT scan. And CT scan, if you think of the meningitis, there is a cerebral edema or hydrocephalus. Seizures. Patient present with the fits. So you should advise the neuroimaging to rule out the secondary causes of the seizure and any neurological sign. If patient is complaining of the severe headache or moderate headache, you are doing the fundoscopy which show the papilloedema, or you are doing the cranial nerve examination which show the third or sixth nerve palsy, or you are doing the motor examination which show there is the hemiparesis or monoparesis. So these are the red flag signs. You are advised the neuroimaging. First investigation is the CT scan, and CT scan is show the confusing region. You should advise the MRI brain. Investigations. Blood CP helpful for the anemia. Blood CP helpful for the thrombocytopenia, patient can present with the brain hemorrhage, and ESR which is helpful for the systemic infection, temporal arthritis or CNS infection. X-ray skull, paranasal sinus or cervical spine if there is the history of the favoring to the sinusitis or cervical spondylosis. CT scan of the head. If the CT scan of the head is normal or show confusing lesion, then MRI with MRA is very helpful. Eye examination, visual acuity and fundoscopy. ENT if you are thinking the sinusitis. Cardiological and renal evaluation if patient is a hypertension, headache, and CSF studies if you are thinking of the meningitis and other conditions. Raised ICP CSF is contraindicated. Other conditions are CNS infection like meningitis, cerebral malaria, viral encephalitis, HIV, other infections, subarachnoid hemorrhage, would show there is the red color CSF. So these are the certain indications you are advised to the CSF. But before you should done the CSF, CT scan is very important. If CT scan show there is a no midline shift or any brain tumor, then you should perform the CSF. If the patient CT scan show there is a midline shift or brain tumor, if you are doing the CSF, chances of the herniation. So that's why you are suspected the severe headache. Initially CT scan, if CT scan is unremarkable and you are thin the CNS infection, then CSF studies. Investigations for the urgent emerging neuroimaging. First or worst headache, particularly if sudden onset. Headache of increased frequency or severity. Increased frequency of vomiting and headache on walking, because there is a walking headache is most probably due to the raised intracranial pressure. Headache triggered by coughing, straining or postural changes also favor to the raised intracranial pressure. Persistent physical symptoms or signs after attack, neurological or endocrine. Okay, let's discuss some topics related to the headache. So second most important is the migraine. So these are the certain pictures. Tension headache, mostly there is the frontal area. Cluster headache, mostly orbital area. Migraine, mostly temporal area. Okay, what is migraine? A disorder of the central nervous system, hypersensitivity to the specific trigger and stimuli, often family history positive. A disorder of the nerve cell in the brain and the blood vessels surrounding the outside of the brain. So structures we have already discussed. Migraine means inflammation. There is the release of the inflammatory substance. Most common inflammatory substance is the substance P, which is responsible for the inflammation of the blood vessels and surrounding tissues and on the outside of the brain, and there is the activation of the pain pathway. Most probably there is the pain pathway is the trigeminal neural. Okay, so there are a lot of theories are implanted for the migraine. Some are successful, some are not successful. Genetic theory, 50% cases family history positive. Some says vascular theories, neuronal theory of the migraine. Latest theory is the trigeminal vascular system and role of the 5-hydroxy tryptophan. Empty neural theory, cortical spreading depression. These are the certain theories which are shown in the different books. So we have already discussed the migraine. It is mostly unilateral, sometimes generalized, pulsatile, most commonly into the young age, 20 to 40 years of the age, more common into the females as compared to the males, and the attacks seen during the pregnancy in 75 to 80% women. So use of the oral contraceptive associated with the increased frequency and severity of the migraine. Then if the patient is the migraine and use of the contraceptive, chances of the ischemic strokes are more, because these contraceptive pills can cause vasoconstriction and procoagulation, and patient is also migraine can cause vasoconstriction, so chances of the stroke are increased when patient is non-case of the migraine and taking the oral contraceptive pills. Okay, this is a classic criteria for the migraine. Episodic attacks of headache 4 to 72 hours. With two of the following symptoms, not all following symptoms. Unilateral, so it is not necessary it is a unilateral, sometimes generalized. Throbbing, pulsatile, aggravation or movement, pain of moderate or severe intensity. So any two of following, one of the following symptoms. So every patient is not present with the nausea or vomiting. So nausea or vomiting, photophobia or phonophobia. So this is a classification or criteria for the migraine headache. Criteria for the hospital admission: if the patient is a status migrainous, patient is a severe headache, vomiting and more than 72 hours. Because patient is the vomiting and oral tablets are not taken. That's why we are hospitalized the patient to rule out the other causes and then given the IV or IM anti-migrainous drugs. Treatment of patient with migraine: a patient with the mild symptoms, paracetamol, brufen or aspirin. A combination of aspirin and metoclopramide. A patient is the vomiting. A patient in the severe headache, we are given the triptan. These triptans are act on the serotonin receptors. Okay. So cluster headache. The common site of cluster headache, one-sided, 15 minutes, sometimes maybe 30 minutes or 3 hours, and it is the severe and short. Look this phase. This phase is reasonable for 3 causes: cluster headache, subarachnoid hemorrhage, and trigeminal neuralgia. So the exact mechanism of the cluster headache is still unknown. The most probably due to the paroxysmal parasympathetic discharge mediated through the greater spatial petrosal nerve and sphenopellatine ganglion. So responsible structure for the cluster headache is the greater spatial petrosal nerve and sphenopellatine ganglion. Risk factors common into the male and small amount of the vasodilator if patient is taking the alcohol. 80% cluster headache patients are heavy smokers and 50% have a history of the heavy ethanol use. So cluster headache is more common into the male as compared to the females. Diagnostic criteria: at least 5 attacks. Full find criteria B and D. Severe or very severe unilateral, orbital, supraorbital or temporal pain lasting 15 to 180 minutes if untreated. Associated symptoms: sweating, that's why we are called the trigeminal autonomic cephalgia, because autonomic symptoms are common: sweating, meiosis, ptosis, eyelid edema, conjunctival injection, lacrimation, nasal congestion, rhinorrhea, forehead and facial pain. So these are the associated symptoms, and it is not necessary in every patient these all symptoms are present. If patient is a unilateral headache, orbital headache, severe with ptosis, eyelid edema, nasal congestion or lacrimation, must be think of the cluster headache. Okay, so cluster headache we are classified into the episodic and chronic. Treatment of cluster headache, the mainstay of treatment is the oxygen therapy. A patient is a severe cluster headache, you should give the oxygen 12 to 15 minutes for 15 minutes. First line treatment: serotonin receptor agonist, dihydroargatamine, non-steroidal anti-inflammatory drugs, viscous lidocaine, and finally the last option is the Botox injection. Botox if symptoms are not improved to the cluster headache. So if anyone asks about in which headache the treatment of choice is the oxygen therapy, your answer is the cluster headache. Prophylactic agents which are role for the preventive: calcium channel blocker, lithium, methotrexate and anticonvulsant, topiramate and valproic acid. These are also helpful for preventing the attack of the cluster headache. Steroids should be given in the cluster headache for the short treatment. A patient in a severe cluster headache, IV steroid should be given. Tension type headache, more common headache, involve into the frontal area, forehead or general headache. Most common type of the primary headache associated with the emotional stress or anxiety. Risk factors more common into the females. Age group, there is the young adults. It is mostly 60% account for the headache. Headache onset is unusual more than 50 years. If the patient age is more than 50 years and he is complaining of the headache, less chances of the tension type headache. Triggering factors of the tension type headache: stress, sleep problem, skip meal, certain foods, physical exertion, environmental factors, female hormonal changes, certain medications. I have already discussed that. Nitrates also worse than tension type headache. Treatment of tension type headache: one is the analgesics, temporary, antidepressant, and proper sleep. The most important treatment is of the tension type headache is the antidepressant drugs, painkillers are SOS and bed rest. So these are certain treatments should be given into the headache. Meningitis, other causes of headaches are the meningitis. These are the common features of meningitis: neck stiffness with fever, headache, neck stiffness with fever, subarachnoid hemorrhage, worsening headache, thunderclap headache with neck stiffness without fever. Sinusitis, headache which involve into the frontal area or basilar area along with the symptoms of the nasal rhinorrhea or sinus and headache which is worse on the lean forward, or headache which is worse into the early morning. Brain tumor due to the space occupied lesion, worsening headache in the late night or early morning. Other headaches are the recurrent headache, tension type headache, cluster headache, and migraine. We are also replaced into the chronic headaches. If acute migraine is not treated, it is replaced into the chronic migraine. If acute tension is not relieved, it is replaced into the chronic tension. And if clusters are not relieved, it is replaced into the chronic. Thank you so much. Any question? Thank you.